Hello, everyone. We are pleased to have you join us for Cardinal Health Lab Exchange. Welcome to today's live broadcast, Colon Cancer Diagnostic Tool, Fecal Occult Blood Testing in the Modern Era. I am Bob Woodard, and I'll be your moderator for today's event. We are delighted to bring you this educational web seminar presented by LabRoots and sponsored by HemoSure. HemoSure is a worldwide recognized immunological fecal occult blood test brand known for quality, accuracy, and reliability. HemoSure is dedicated to saving lives and educating patients on the importance of getting screened for colorectal cancer. For more information, visit hemosure.com. We have a few important announcements to make before we begin. This presentation has been approved for continuing education credits. Please click on the CE button on the bottom left corner of the auditorium. This will direct you to the necessary site and form needed for your credits. This webcast is designed to be interactive. We encourage you to ask questions during the presentation. To submit your questions, you can type them into the Q&A box, which can be found by clicking on the green Q&A button at the lower left of the presentation window. You can enlarge the slide window by clicking on the screen icon on the lower right-hand corner of the screen window. If you have any technical problems viewing or hearing this presentation, please click on the support button in the upper right-hand corner of the presentation window, or submit your questions in the Q&A box on the lower left. Following this presentation, head over to the Community of Learning in the Lab Exchange lobby to have the opportunity to engage in live chat and have more of your questions answered on the spot about colon cancer diagnostic tool, fecal occult blood testing in the modern era. I would now like to introduce today's speaker, Rob Kisfalusi. Rob is the Southeast Manager for HemoSure. He's a specialty expert in rapid diagnostic medical devices with enthusiasm for colorectal cancer awareness. His belief is that we're all part of a team, and the goals of the team are simple: save lives and/or improve the quality of life. The tasks for each of us may differ, but the goals should remain the same. Rob's favorite task is educating healthcare providers on new recommendations and methodologies. He loves to see the aha moment when they not only understand how to perform a test, but more importantly, why. Rob will continue to learn, educate, and disseminate beneficial information to the masses. Please join me in welcoming Rob to today's event. I will now turn the presentation over to him.
Thank you, Bob. I appreciate that. Welcome, everyone. I appreciate the time that you're going to spend with me today. We're going to do some learning on a topic that's very near and dear to my heart, or should I say near and dear to my butt. Before we get rolling, as I talk through my introduction, you're going to see some poll questions. Please answer those poll questions, everyone, so that I have an idea of who you are, so that we can make this lecture tailored a little bit more to the audience. Again, welcome. I am Rob Kisfalusi, and we're going to speak in generic terms, not necessarily having anything to do with my role here at HemoSure. So you will be able to walk away with this, hopefully, after the hour that we spent together, with a better understanding of what new recommendations are and how to have better patient care, as well as a revenue stream for a lot of your facilities with the newer style of fecal occult blood testing. I understand that a lot of you are fully aware that the fecal occult blood test is used in many different areas, not just colorectal cancer screening. We're going to focus on the colorectal cancer screening aspect of the fecal occult blood test today. So as we move through everything, we will answer questions at the end, and hopefully if you have more in-depth questions or would like to discuss different things, we can join each other in the community of learning after the conclusion of the lecture. So once again, thank you for your time. And again, we're going to talk about the guaiac methodology of colorectal cancer screening versus the newer technology and technologies. We're going to go over a few of them. We're going to focus on what was recommended by the American College of Gastroenterology when they made their latest round of updates at the end of 2008. We're going to talk about specifics between different methodologies. We're going to talk about why certain methodologies are recommended over others. If you see me out and about, I do my share of traveling to different trade shows and different meetings. You can say, hey Rob, saw your lecture, loved it, hated it, give me feedback there as much as you'd like to do so. You can commonly refer to me as the poop guy. That's what I'm known out there in the field as. So if you forget that my name is Rob, just say, hey poop guy, come on over here, I got a question for you. And we will have a discussion for whatever you want to do. I'm going to give you a couple seconds to finish off these poll questions, but in my introduction, Bob spoke something that's very passionate to me. All of us in healthcare get focused on our daily tasks. We have a lot of work on our plate because if everyone is like I am, you're doing the job of 3 different people, and you're expected to do it all on your own. So we get focused on our daily tasks in this healthcare business that we're in, and we have a lot to do that a lot of times we lose sight of the fact that we all have a common goal. That common goal is either to save lives or to make the quality of life better for people. When you take a step back and you think of it in terms of that frame of reference, it really gives us a little bit of a breath of fresh air or a breather from our daily tasks to really focus on what's important and why we do what we do. So whether you are a supplier, whether you are a vendor, whether you are working in a healthcare facility in a capacity of being a nurse, an MA, a physician, somebody in procurement, someone that works the front desk, somebody that's in billing, we're all in this together. We all have the same common goal. Let's try to work together to help everyone out. Think of it in terms of your own family members. What kind of treatment would you like for your mother, your father, your son, your daughter, your brother, your sister when you go in to get your healthcare needs taken care of? If we really focus on those types of things, we try to make it an easier environment for everyone to achieve the same goals that we have. We're almost finished with the poll questions, and we'll go ahead and wrap those up in a second, and I will begin with the actual lecture at hand. Thank you for allowing me the extra couple minutes to give my viewpoint on how we're all together in this endeavor that we call healthcare. I appreciate that. I'm going to go ahead and get started right now with the actual slides. Slide 1, we're right here. We're going to be talking today about colorectal cancer screening and the difference between the guaiac-based testing methodology and the new FIT test. So we're in the modern era now. Colorectal cancer, what is it? Quite simply, it's cancers of the colon and rectum. I bet that wasn't a surprise to any of you. You know exactly what that word means and what we deal with it currently. So why should you care about colorectal cancer and colorectal cancer screening? Well, first of all, there were about 137,000 almost cases of colorectal cancer in the United States in the year of 2014. Out of those nearly 137,000 cases, we had over 50,000 deaths from colorectal cancer in the United States. That is more deaths than the number of people that visit Disney World on any given day. When we look in terms of that, that means that colorectal cancer is the number 2 cancer causing deaths in the United States. It's higher than many other cancers that we pay a lot more attention to, and we'll talk about the differences in why we pay attention to different cancers ahead of time. You know, this is a disease, because it has such a high occurrence and such a high death rate, that we need to focus more attention on. We need to focus more attention on it to get some campaigns out there, and a lot of groups have. The American Cancer Society, the American College of Gastroenterology, the Colon Cancer Alliance, but it's a topic that a lot of people don't want to focus on. They don't want to think about it because, let's face it, the cancers that come from your butt are a lot less sexy of a topic than the cancers that come up here on the ladies. We like to talk about these all the time. We like to talk about breast cancer awareness, and we do a great job in this country of getting awareness surrounded in screening for breast cancer, but breast cancer doesn't come close to killing as many people as colorectal cancer does in the United States. So it's a very important topic that we're about to discuss today. I'm going to show you a slide right here where there's a collage of a lot of different people that have been affected one way or another in their lives by colorectal cancer, or people that are just outspoken proponents of screening, and you may recognize a lot of the people that are on this list or what they have to do with colorectal cancer. So this is a disease that reaches across all socioeconomic boundaries. It reaches across all ethnic boundaries. This disease affects everyone. Let's take a look a little bit about what we're trying to do when we're screening for colorectal cancer. A lot of colorectal cancer can be stopped before it ever becomes a cancer. We start with this precancerous polyp that you see in the photograph in front of us. If we detect this precancerous polyp, or even cancer at a stage 1, we have greater than a 74% chance of a 5-year plus survival rate. That means we need to do a better job of screening people, getting them in to see their physician, getting their screening test done regardless of the methodology in order to prevent people from developing this disease. If we wait until that cancer has developed and grown to a stage 5, we are looking at a survival rate of 5+ years of 6% or less. That's a devastating percentage when you think about how easy it is for us to catch this disease long before it ever turns into cancer at a stage 1. So what we're looking for when we do our colorectal cancer screening, we're hoping to find these precancerous polyps that are bleeding, that show an increased amount of blood in the lower GI before we ever have to deal with a disease such as cancer that gets to stage 1, stage 2, 3, or 4. The ways that we go about that screening are different, and we're going to go over some of them right now. The recommended screening tests and intervals, according to the U.S. Preventive Services Task Force, are as follows. There are 3 of them. They recommend a high-sensitivity fecal occult blood test, which checks for hidden blood in 3 consecutive stool samples, and this should be done every year. They also recommend a flexible sigmoidoscopy. It's where the physician uses a flexible lighted tube, sigmoidoscope, to look at the interior walls of the rectum and part of the colon. This is about the lower quarter to lower third of the colon. We do this every 5 years, and then we do the high sensitivity fecal occult blood test in between there as well. The sigmoidoscope is effective because many of these colorectal cancers center around right near the rectum or in that area, about 50% or more. Colonoscopy is what is considered to be the gold standard in the recommendations, and the physician's going to use a colonoscope, flexible lighted tube, to look at the interior walls of the rectum and the entire colon. This is recommended to be done every 10 years in the general population, beginning at age 50 up to 75. For your average population, African Americans should be tested beginning at age 45. And if you have a family history of cancer in your family, you need to be screened starting 10 years before your family member, first degree family member, was diagnosed with cancer. When we're talking about the colonoscopy, one thing to keep in point as well is that samples of the tissue may be collected for closer examination, or these polyps may actually be snared and removed as part of a colonoscopy. So the colonoscopy can be used as a screening test or as a follow-up diagnostic tool when the results of the other screening tests are positive. There are other methodologies out there, but the Preventative Services Task Force recognizes that they're out there, but they have not met the recommendation list yet. Although most expert groups generally recommend the high sensitivity fecal occult blood test, the sigmoidoscopy, or the colonoscopy as the 3 standard tests, the other tests that are available are stool DNA tests, virtual colonoscopies, double contrast barium enemas. The only one on this list that we're really going to go through any kind of detail on is the stool DNA test. There is a newer test that's out now, and there are a lot of questions surrounding this test. It's new, it's getting a lot of press. A lot of people come by and ask me questions on what I think this test is about, and I will say that I think the stool DNA test, or molecular testing in general, is probably going to be the future. That's probably where we're going. In August of 2014, the FDA approved this stool DNA test. At the same time, the pilot program known as a parallel review, the Centers for Medicare and Medicaid Services, so CMS, proposed national coverage for the test. They agreed that they were going to reimburse the lab for doing this expensive stool DNA test. As I stated earlier, to date it's not been incorporated into the clinical practice guidelines, or it's not the recommended test yet by the U.S. Preventative Services Task Force, but we're going to monitor that test. We all have high hopes for molecular testing to be the future. At this point, when you do a stool DNA test, it will provide you with results that are similar to a FIT test, which is what we're going to talk about in detail in this lecture. And at the end of the day, a negative result on the stool DNA test does not mean that you have no cancer. A positive result on a stool DNA test does not mean that you have cancer. The sensitivity and specificity of that test come out to be very similar to what the FIT test is. So my bottom line, and another bottom line for the U.S. Preventative Services Task Force at this point, is to say that with the cost factor built in, you might as well do the $5 FIT test instead of doing the $500+ stool DNA test at this point when the results are similar. Hopefully, as we move forward over the next handful of years, maybe within the next decade, we're going to see drastically increased results for the stool DNA test, so there's something to keep a lookout for in the future. The virtual colonoscopy is a sensitive CT scan, the double contrast barium enema, again, another methodology, but there are a lot of polyps that we're looking for that are not the nice round polyp that we talk about in this photograph that we have here. Very easy to detect. Many polyps are very flat. They're easily missed by these other types of testing, and sometimes easily missed by something as advanced as a colonoscopy. So just to keep an idea out there, there are other methodologies that are available, but the 3 that we discussed here are the recommended screening tests. You've got your high sensitivity fecal occult blood test, your flexible sigmoidoscopy, or your colonoscopy. Let's talk about the original stool cards. This is a gFOBT, or guaiac-based fecal occult blood test. It was introduced in 1971 to the United States. The term guaiac is the paper surface used in the test that actually has a resin from a tree, guaiac tree actually, that the paper surface is impregnated with. The test involves dietary and medication restrictions for several days prior to the test. Some of those restrictions include iron supplements, animal meat containing animal blood. I don't know any animal meat that doesn't contain animal blood, so if you do, let me know. Several different vegetables that may cause peroxidase activity, like radishes and cauliflower, horseradish. You also have to abstain from your vitamin C. You should avoid excessive drinking. You should avoid your non-steroidal anti-inflammatory drugs. All of these prep should take place before you do your typical guaiac-based fecal occult blood test. And for the guaiac-based fecal occult blood test, the valid test requires 3 consecutive samples on these cards. So what has happened over the years, since that test was developed 44 years ago, or introduced in the United States market over that 44 years ago, is that patients were not complying with the PrEP. They were not doing the dietary and medication restrictions that they were doing. They weren't doing the 3 days of testing. They may do one test, decide that it wasn't a pleasant experience, go ahead and throw those stool cards away, never return them to their doctor. All kinds of different messes that are involved in this. So the doctor prescribes 3 cards to the patient. 50% of the time, those 3 cards go in the garbage and are never to be seen again. It's a waste of money on the physician's side, and the patient never gets screened. So what happened along the way, the physician has decided that they were going to take things into their own hands, literally. Started performing digital rectal exams as part of the annual exam. Now, digital rectal exams are performed for a lot of different reasons, but the doctors decided, well, since I already have this sample on my fingertip after I do a digital rectal exam, I'm going to go ahead and use a guaiac-based fecal occult blood test, and I'm going to kill 2 birds with 1 stone while doing this. So if those of you that don't know what a digital rectal exam is, the physician gloves up, lubes up, inserts a finger into the rectum, and they're checking for abnormal areas, lumps, lesions, a lot of different things right at the anus and rectum. It is not an acceptable form of colorectal cancer screening by itself. And on the College of American Pathologists website, in this 2-sentence paragraph, it says, even when done in office with a guaiac-based fecal occult blood test, you're going to miss about 95% of cancers. So it is completely ineffective for physicians to be doing digital rectal exams with a fecal occult blood test guaiac-based card. Now that we have that out of the way, and we realize that a lot of us need to start questioning the methodologies in which we currently are doing the cancer screening, the ACG has good news. They support the joint guideline recommendation that older guaiac-based fecal occult blood tests be abandoned as a method for colorectal cancer screening. Furthermore, the ACG recommends the FIT as the preferred cancer detection test. I haven't gone over it up to this point, but we'll just say that the terms gFOBT or FIT are interchangeable, and those terms stand for immunochemical, immunologic, immunoassay. You'll hear those terms used interchangeably, fecal occult blood test. FIT, gFOBT, same thing. Newer test, you'll hear it called that. So if we're not talking about the guaiac-based fecal occult blood test, we're talking about FIT or gFOBT. When we're talking about the digital rectal exams, before we get too far ahead, there are many FIT tests that can be utilized off-label by doing a sample produced by a digital rectal exam. So we don't tell physicians how to be physicians. If they want to continue to do the digital rectal exam, we would recommend that they at least use a test like the FIT test, which does not require the patient to prep ahead of time. This is key. What we're trying to do in healthcare is we're trying to reduce costs in the system, but we're trying to screen more of the general public. The ways that we do about screening more people yet taking costs out of the system are we're looking for ways that are actually costing us more money. When a doc is doing a digital rectal exam with a guaiac-based card, we end up sending a high number of people to get a colonoscopy because we received a positive result. Yet that positive result is produced by the fact that the patient has not prepped by dietary or medication restrictions before taking the test. So an example, patient comes into the emergency room of the hospital complaining of lower GI pain. Fecal occult blood test is performed with a Hemoccult card by a digital rectal exam from the ER physician. A positive result comes up because the patient had steak, broccoli, and cantaloupe for lunch yesterday, so they're referred upstairs to get a colonoscopy. The cost of that colonoscopy, the anesthesia, the bedtime, everything associated with that colonoscopy has now been wasted and added to the cost in the system because we got an invalid result from that test because of the methodology that was used. The package insert for that guaiac-based fecal occult blood test nowhere states that one sample is enough, and nowhere does it state that the sample received by doing a digital rectal exam is enough sample to smear on that card. So let's switch to what we believe should happen. If the physicians in the emergency room are going to continue to do the digital rectal exam to get that sample that they need, that's fine. At least use a test, like I say, that didn't require that the patient prep before they came into the office. With the FIT test or the IFOB, there are no dietary, no medication restrictions before the patient comes in to get that test done. Some of the advantages are listed right here. We just went over the top one. No dietary or medication restrictions means that you get a better patient return rate. Not only a better patient return rate, you're going to get a better result from the test that's actually done because you don't have the interfering substances that you do with the other methodologies of fecal occult blood testing. We have an increased specificity and higher sensitivity with the FIT test or IFOB over the guaiac-based cards. That means that you're going to get fewer false positives for colorectal cancer screening. That goes a great way to reducing that cost in the healthcare system that we're looking to reduce. The FIT test or IFOB is specific to lower GI bleeding, which makes it the ideal test for colorectal cancer screening. Now, I know a lot of you out there are saying, that's great, but we utilize a fecal occult blood test for things other than just colorectal cancer screening. And I understand that. We have pages and pages and pages of ICD-9 codes that are going to show us different conditions that we may find that will cause increased blood in the lower GI. Also understand that a lot of physicians are not just looking for blood in the lower GI, they're also looking for blood in the upper GI. The first rebuttal that they will give as a reason for not wanting to switch over to the FIT test is they believe that the guaiac-based card kills two birds with one stone, meaning they can look at upper GI and lower GI with one test. My refute to that rebuttal would be that you're not killing two birds with one stone, you're merely maiming two birds with that one stone, because while it is true that that guaiac-based fecal occult blood card will show bleeding in upper and lower GI, it's not the ideal test to use for either situation. The cutoff level is still too high, and there are dietary restrictions for the lower GI portion. We've already gone through those. And for the upper GI bleeding, the pH level is not where it needs to be. So there are some products out there. We recommend using a gastrocult card for upper GI bleeding. The physicians should have an idea about exactly where they're looking, or a suspicion for whether they're looking for upper or lower GI bleeding to begin with. So why not use a very specific test to substantiate your belief that you're going to find something there? We know that if a patient has coffee ground emesis, or if they have black tar stool, you're probably looking for an upper GI bleed. Go ahead and use a gastrocult card, because it's a very specific pH balanced test to test for that upper GI bleed. If you suspect a lower GI bleed, then please use the FIT test or IFOB, because there are no dietary or medication restrictions for that test, and the cutoff level is much lower where it needs to be. We have new CPT codes. When I say new, I mean over the past 10 years. FIT is nothing new. IFOB is nothing new. My particular product has been CLIA waived and FDA approved in the United States since 2004. So we're in our 11th year now. This is not brand new information. It's been disseminated for quite a while. But we have billing codes out here. The new billing codes are to be utilized the same as the older billing codes are utilized. You must put the QW modifier on the end of the codes to show that the test is CLIA waived. One of the great aspects about this FIT test or about the IFOB, if you look at the national reimbursement based upon Medicare, it's $21.65. This $21.65, when you're working off of reimbursement, indicates substantial revenue potential if you're at the physician office level or if you're at the lab level, reference lab level. You can see with a cost of in the ballpark of $5 to $6 per test, how making $15, $16, $17 per patient could be beneficial to your facilities. So there are new codes to be utilized for the IFOB. They're used the same way as the older codes were for the guaiac-based fecal occult blood tests. We talk about why people don't get screened for their colorectal cancer needs, and Berkeley came out with a paper a handful of years ago, and their summary was basically that we believe that the colonoscopy is the gold standard, but really the gold standard for colorectal cancer screening should be whatever we can get the patient to complete. Whether it's a guaiac-based fecal occult blood test done in the right methodology with the right prep and the right 3 cards, or the FIT test, or the colonoscopy, we need to provide people options. If we provide them only one option, which is a colonoscopy, and they either are afraid of the procedure because they've heard stories from other people, they're afraid of the procedure because they have something in their mind that may be untrue, whether their insurance won't cover the colonoscopy, which is rare, or whether they just don't have insurance and can't afford the colonoscopy, we have to be able to provide the general public several different options. So this wellness letter from Berkeley said, you know what, the gold standard is whatever we can get the patient to actually complete. And I think that's worth noting. How about, just plain not being aware? The more advanced form of fecal occult blood test is the FIT test, and it's superior in several ways. This comes from Gastroenterology in April of 2012. So again, this is not new information. It only requires 1 stool sample instead of 3. Patients are more apt to complete the test. It's more accurate than the standard test because it identifies antigens in the blood, and it's not looking for heme. So the guaiac-based fecal occult blood tests are looking for heme. It doesn't differentiate between whether it's animal blood, human blood, or other. It works off of peroxidase activity, and as long as there's blood or peroxidase activity present, it's going to show you a positive result. The FIT, or the IFOB, is only going to show you a positive result when that antigen-antibody complex shows that there is an increased amount of human hemoglobin present in this test. We're not looking for heme at all. We're only looking for the globin portion of human hemoglobin. So it's important to note the differences between the 2 tests. The FIT is being used more and more in the U.S., and we continue to gain, but 60 to 65% of the physicians out there in the United States are still using the outdated guaiac methodology of testing, even though at the end of 2008 the American College of Gastroenterology said abandon that method. So change is slow. I like to say the oxen are slow, but the earth is patient, meaning if we all continue to work together to spread this information, we will eventually get the switch from the outdated product over to the newer product. The Brits get it. They say that there's persuasive evidence that the new blood test FIT is a more effective test for bowel screening. Everybody understands that. That's the Cancer Research UK's Director of Policy. We, for whatever reason in the United States, are slow to adapt. Canada has stated that a colorectal cancer screening program similar to those in existence for breast and cervical cancers would reduce death rates by up to 83% and reduce incidence by up to 81%, according to a BC study in the Canadian Medical Association Journal. I don't know how more plainly to put it to folks. We need to change what we're doing. We need to screen more people with the proper screening test so that we can save more lives. Is anybody paying attention to this? I just said that 60 to 65% of the physicians in the United States are still using the outdated guaiac method of testing. Ranges in reasoning for This is what I did in med school. It's what I'm used to. It's what I know. It's what I'm comfortable using. It's what's available to me. Any number of reasons why they're still using it. There were over 50 million fecal occult blood tests, and we're talking about guaiac fecal occult blood tests performed in the United States in 2011. There were only just over 5 million IFOB or FIT tests performed that same year. As you can see, the huge advantage goes to the guaiac-based fecal occult blood test. We need to change that. 6,000 plus labs reported quarterly proficiency testing methods as the guaiac or the high sensitivity guaiac to cap API and MLE. That's a lot of labs that are still using an outdated methodology. Imagine what we could be doing, how many lives we could be saving if we just made the simple switch over to the antibody test instead of the test that works off of a guaiac peroxidase activity. You know, ignorance is no longer an excuse. We talked about this information and how it's been out there. We're coming up now in a handful of years on 10 years since the ACG updated its recommendations. So patient benefit is something that people can't go off of, that they have no idea that it's more beneficial for the patients. But look at the cost and the ROI. You know, the average cost of the guaiac-based card is $1, and it's reimbursing at just under $5 currently. The average cost for the FIT or IFOB is in the ballpark of $5 to $6, yet it's reimbursing at $16.50 on the national average. If it's better patient care and it's a revenue stream for your facilities, why would you not want to switch to the methodology? You know, for benchmarking, as part of the Affordable Care Act and accountable care organizations and the future of medicine, outcome-based medicine is here. You're going to start being penalized for readmissions. You're going to be penalized for things that happened that you missed. Imagine this scenario. We talked about the patient coming into the emergency room. The emergency room physician performs a digital rectal exam, smears that sample on the guaiac-based fecal occult blood test, and gets a negative result. Says, hey, everything's good to go here. We don't need to worry about anything. That patient develops colorectal cancer within the next couple of years. That patient dies from colorectal cancer, and the family starts to do a little bit of research and realizes that they've done all their studies on colorectal cancer screening recommendations, and that they go back and look and see that the physician that performed that test performed a test which was recommended to be abandoned by a governing body, such as the ACG. Now they're going to sue that hospital and that physician. How much is that going to cost you in the overall scheme of things in the healthcare field? So the days of just performing things because it's what we're used to performing or because we can't afford to make the switch, we're showing you proof right now of how you can't afford not to switch over to IFOB. Again, we all need to work together to achieve this goal, to make sure that we understand what the recommendations are, why the newer test is more beneficial than the old test, and what we're going to do about it. Let's take a look at another study that was done. This study compares different FIT tests. So we talk about how we want to get everybody to switch over to the FIT or IFOB from the guaiac-based testing method. We know that we should do that. So you should be able to just contact your distributor, such as Cardinal, and say, hey, give me the FIT test, and they'll just pick one for you, right? Or you can base it upon cost or whatever your methodology is. Throw a dart at a board, who knows? But not every FIT is created equally. They all work on the same mechanism, which is an antibody test, but each test is completely different. They all have different cutoff levels, and this is hugely important when you're trying to weigh that balance between patient care and cost effectiveness. They all have different collection methods. There are different packaging options that are available with different manufacturers for your FIT test. There's different processes to actually run the test in your lab. Each test uses different antibodies. I won't mention the company, but there was a company that was the market leader in FIT a handful of years ago, and they were forced to withdraw that test from the marketplace due to some abnormal results, which were coming from the antibodies that they were using. This company was outsourcing their antibodies to a company in China that was providing them, and the results were not consistently cutting off at the level that they selected. So the results were doing this, sometimes higher, sometimes lower, and we know statistically that we should be seeing a positive result somewhere in the ballpark of 9 to 14% of the time on a FIT test. And if you're seeing results outside of that, you need to question a few different things. One of them is how the patient's doing the test. The other could be how you're processing the test. And the third could be the actual test itself. So when we talk about these cutoff levels, each manufacturer sets their own cutoff level. The chart that I've given you in front here was taken from a study from the Clearview test that was done a handful of years ago. And this test went through different cutoff levels to show what results you're going to get. So at the 50 nanogram cutoff level, there were 17 true positive results. We didn't miss any at all, which is great. 75 nanograms, however, once we take that one step up, we're missing a cancer already at 75 nanograms. As you go up the list, we're missing more and more cancers already on these lists. Again, I'm not going to associate names with these different companies, but I will say that there are many companies out there that set their cutoff level at 25 nanograms because they don't want to miss any cancers. 25, in my opinion, may be a little bit low because, again, we're trying to reduce the number of useless colonoscopies that we perform in our facilities. With a 25 nanogram cutoff level, you're going to find a lot of people that that's just their average amount of blood in their lower GI on any given day. The upper levels, there are some companies out there that set their cutoff level at 100. There are some companies out there that set their cutoff level at 300 because they understand the aspect of wanting to limit the number of colonoscopies that are performed and saving money that way. However, they're not really taking into account the number of cancers that you're missing by increasing those cutoff levels. So this is a very informative slide for everyone. We'll talk a little bit about something that's not on this slide, and again, it talks about recommendations for fecal occult blood testing, or the FIT, or the IFOB, all right? Before we get into the summary, I'm actually going to go back a slide. We talked about different methodologies and different cutoff levels. We went into detail about the cutoff levels, the collection methods. Just about everybody in the IFOB or FIT world agrees that 2 tests are better than 1. Statistically, you're going to get about 17% better results by doing 2 consecutive bowel movements than you will by doing 3, which is what the traditional cards called for. There is 0 statistical difference with a FIT between 2 tests and 3 tests. So if your docs are ordering 3 consecutive bowel movements on the FIT test, they're just wasting that extra test. They're wasting money on it. There is 0 statistical reason to do so. We do have studies that support that. Now we find that because we all agree that 2 tests are better than 1, and before I go further, let's talk about the semantic difference between required and recommended. Again, I say 2 tests are recommended, and that's agreed upon by everyone, but only 1 test is required, and you're only being reimbursed for 1 test. So these are key factors to keep in mind as well, especially when we talk about packaging options. So there are some manufacturers out there that say, okay, if 2 tests are recommended, we're going to go ahead and we're going to combine 2 tests into one so that not only are we not increasing the cost, but we can take care of those 2 stool samples. Well, as we're looking at this cutoff level chart, and we think about what's normal in a human being and what is clinically significant, let's just say that myself and 2 other people, let's say I have a normal amount in my lower GI of 30 nanograms of blood per milliliter on any given day. Let's say that the 2 other people next to me, they are 10 and 5 respectively. So if we all do a 2-day test and we combine it, or collect 2 days of sample and we combine it into one test, what's going to happen to the other 2 folks next to me is nothing significant. They're both going to show up as negative, because if we double the 5 we get 10, and if we double the 10 we get 20. We're still under that 25 nanogram cutoff, which a lot of manufacturers use. However, on my test, because I'm normally at 30, if you double my test and then run that in one, it's going to show that I have a concentration of 60 nanograms per milliliter of blood in my lower GI, and that's going to show as significant. You're going to refer me for a colonoscopy. This colonoscopy and the costs associated with it, not to mention the percentage of perforations that occur with these colonoscopies and the cost that's associated with them, is a waste of money, because clinically I should be negative. That's the danger when you combine 2 samples into one test. I believe there is actually a manufacturer out there right now that is saying it's okay in their package insert to combine 3 days of a stool sample to be run in one FIT test. So again, you run the risk of spending more money doing needless colonoscopies. When you're going to make the decision to switch over to FIT, really study what's available to you, study what your options are, find out what your pathologists and what your medical directors think should be the correct cutoff level. Find a company that's going to provide the packaging options combined with the cutoff level and the methodologies that are going to be right for your facilities based upon the results that you're looking for. So in summary on there, colorectal cancer is the 2nd leading killer in cancers. We talked about this. Breast cancer is a sexy topic to talk about. It's something that everybody wants to get behind to promote, but we need to do a better job of promoting screening for colorectal cancer as well. The ACG, in the article released at the end of 2008 and published, recommends abandoning the older guaiac-based fecal occult blood tests as a method for colorectal cancer screening. According to the College of American Pathologists, digital rectal exam is not an acceptable form of colorectal cancer screening, even when used with a guaiac-based fecal occult blood test. You're going to be missing 95% of what you're looking for. Now we talked about why physicians have taken matters into their own hands, because they couldn't trust their patients to do the proper prep and to return the guaiac-based fecal occult blood cards that they had in the past. But I promise you, FIT has a higher patient compliance rate based upon a couple different things. The collection methodology, a lot of manufacturers have made that collection a lot easier for the patient. The patient doesn't have to prep ahead of time. They can go home and do it immediately that night or that evening or the next day. They don't have to wait to do their test. And they only have to do 1 instead of doing 3. So the FIT, with no instruction whatsoever, just handing the kit to the patient and saying, go home and do this, follow the instructions, will come back to you around 50% of the time. With proper patient instruction and taking that extra minute and a half that it takes to show your patient what to expect before they go home to complete that test, we have over an 80% return rate with the FIT test. So Physicians, you may doubt us to begin with, but we will tell you, you will see higher patient compliance rate. And what is the federal goal? We didn't mention it up to this point, but the federal goal is to have 80% of the viable population tested for colorectal cancer screening by the year 2018. That is a lofty goal. We will not reach that goal unless we all work together and do our part to get the people that are in that age range, 50 to 75, to get screened, unless we show them the different methodologies that are available to them, unless we encourage them and continue to encourage them to take advantage of these tests. 80% by 2018 is a huge goal, but we can do it if we work together. Another point to remember with FIT or IFOB may generate significant revenue for your practice. If you're a physician office or if you're a lab and you work off of reimbursement, there is no reason not to avail yourself of the revenue potential and the better medicine that's available to you with the FIT test. And according to the Berkeley paper, what did we say? The gold standard is whichever test that you can actually get the patient to complete and return. Because unless you complete and return your test in the proper method, you haven't been screened. Your HEDA requirements haven't been met. Nothing has been done. So when we talk about colorectal cancer screening, obviously I have a passion for it, but it's very important. We can save lives. We can reduce the incidence of colorectal cancer. We can reduce the death rate for people that actually develop colorectal cancer. We all need to do our part of getting that 60 to 65% to switch over to the newer methodology, and we need to continue to research and develop these newer methodologies such as the molecular testing, where the results are going to get even better and more worthwhile as an indicator as to who needs to get a colonoscopy and who doesn't need to get a colonoscopy ahead of time. So while you sit there thinking about that and we ponder what's happening in the world of colorectal cancer awareness and colorectal cancer screening, again, I'm going to bring this slide back up. Think about the people that are listed here on this collage, how they were affected by colon cancer or colorectal cancer. Think about the people that you know, friends, family members that have been affected by this disease. Think about how many of them could have been prevented ahead of time by a simple $5 poop test. Thank you for your time, everybody. Open to questions now. Please give me your concerns and let me try to answer your questions for you. Give me your concerns and let me try to answer your questions for you.
Well, thank you, Rob, for that informative presentation. I'm thrilled to be part of the Cardinal Health Lab Exchange. Before we start the Q&A session, I'd like to remind our audience that you can submit your questions in the Q&A box that can be found by clicking on the green Q&A button on the lower left of the presentation window. We'll try to answer as many questions as we can. So with that, we'll see if we have any questions at this point. Meanwhile, I would like to thank our sponsor, HemaSure, for making today's educational webcast possible. And after the presentation, after we conclude, please make sure to head to the community learning following to have the opportunity to engage in a live chat with Rob Kisfalusi and your peers, as well as have any questions answered that you may have. And learn more, and talk to Rob about colon cancer diagnostic tool, fecal occult blood testing in the modern era. If we don't have any questions at this point, I'd like to remind everyone that today's webcast will be available for on-demand viewing through October of this year. You will receive an email from LabRoots alerting you when this webcast will be available for replay. We invite you to forward that announcement to your colleagues who may have missed today's live event. Again, head to Community of Learning to talk to Rob. I hope to see you all again next time. And until then, thank you and goodbye.